Hello, and welcome to the third conversation in a series surrounding Health Forward Foundation's new direction toward health equity through a more inclusive economy. In my previous conversations, I sat down with Jeff Jolly, Executive Director of the Local Initiative Support Corporation, or LISC, and the Mayor of Kansas City, Missouri, Quentin Lucas. If you missed those discussions, I encourage you to go back and watch. Each of these conversations has helped us paint a full picture of where Health Forward is headed. In this conversation, I sat down with Dr. Daphne Bascom, Vice President of Population Health at St. Luke's Health System. I wanted to learn more about what hospitals are doing to address implicit bias and structural racism in care delivery. And now, please enjoy my conversation with Dr. Bascom.
I think we have on the same jacket in different colors.
Do we have on the same jacket? That is hilarious.
Very.
Oh my goodness.
I've got the same kind of buttons.
Yep. Same buttons. Well, great minds think alike in great style. Well, thank you so much for taking the time to sit down with me today. I always enjoy the opportunity to speak with you, so appreciate it very much. So, first question, let's just kind of get everyone centered on who you are and where you are. So tell us about your role within St. Luke's Health System.
First, Qiana, thank you for taking the time to speak with me today. I really enjoy the opportunity to hear what you're thinking about. I am the Vice President for Population Health at St. Luke's Health System. I've been with the health system since April of 2019. A lot of people don't necessarily know what population health is, but I have the privilege of working with an amazing team of nurse care coordinators, social workers, community health workers, and we support the needs of our physicians and the other members of the care team. My job really is to keep people out the hospital.
You know, and that's such a different model than what we're accustomed to, right? The system is accustomed to thinking inside the bed and thinking about a sick care system. And you are really working to build a healthcare system that's focusing on prevention and people and their ability to be healthy and thrive in the community with your care team. So that's a wonderful place to be in.
That's the goal.
Yep. So from your vantage point, what are some of the social factors that are impeding health? You're seeing this on a daily basis. What are you seeing come in?
So we started screening for social determinants of health at St. Luke's back in October 2019. And just for your listeners' perspective, the social determinants of health are everything that lives around us. It's the environment where we live, where we learn, where we work, where we play, where we grow older. Those are things that happen outside of the healthcare system. And what we're seeing on our screening is that we're identifying opportunities to support our community members as it relates to transportation, education, access to healthy foods. The needs are diverse. They've grown over the course of 2020, as many people might expect. But a lot of it are the fundamental components of what people need to be healthy. And one of the core things that we're seeing, which is difficult to address, is even housing security.
Yeah, agreed. We're beginning to see or to hear housing talked about at every table that Health Forward is at. And, you know, it's interesting. You mentioned nutrition and healthy access to healthy foods. So much of the system is focused on food insecurity, and those two things go together, but they're not the same. They're not the same. And so I really appreciate the focus on access to healthy foods because I am of the mind that food in and of itself is one of the key issues that is really breeding this chronic disease in our communities, and especially in the Black and Brown communities. And so really appreciate the focus on that. So at Health Forward, we say the social influences of health because communities are resilient and our circumstances don't necessarily have to determine our outcomes. And from my vantage point, racism and bias, especially in the healthcare system, but not only, is the predominant social influencer of health for people of color. There's a lot of talk about this across the country. The AMA is talking about it. Public health is talking about it. And I'm really curious as to how St. Luke's health system is addressing implicit bias and anti-racism as a part of health equity and care.
Qiana, that's a good question. And I'm glad you actually identify it as a social influence of health, although it's not necessarily something we actually screen for. So again, I've only been at St. Luke's since 2019, but the work and the focus on equity preceded my arrival at the health system. St. Luke's has had a medical director of diversity, equity, and inclusion, Dr. Michael Weaver, for many years. Dr. Weaver is an emergency medicine physician and a UMKC graduate, and he's long had a focus on DEI, issues related to LGBTQ, really trying to advocate for ensuring that we focus on equity across the health system. He partners closely with Nikki Beard. Nikki is our director for strategic diversity initiatives, which primarily focus internally. So how are we addressing equity as it relates to our employees and educating and making sure that our employees are meeting our community members with a lens of equity, compassion, and reducing the bias that we all bring to the table. So both as a collaborative, the two of them lead our Health Equity Council. And our Health Equity Council has been focused on many different things. Probably 4 or 5 years ago, the health system took the 1-2-3 Equity Pledge that's sponsored by the American Hospital Association. And that pledge has actually helped focus our own direction on where we're helping to close the gap on some of the issues related to equity and structural racism. And we've been focusing on some of it's very basic, collecting the data. So if you don't have good real data, race, ethnicity, language, and other socio-demographic data, you don't know your community and you don't actually have a good opportunity to identify where there's opportunities to improve. We've also been focused on cultural competency training, and that includes implicit bias education. We all bring biases to the table, and the first thing you have to do is acknowledge it. But without some of that education, communication, it's hard for our care providers to take off that lens and acknowledge that you can't walk in the shoes of every person that you're seeing at the bedside or in your clinic. We've also been focused on diversifying who you see at the table, both from a governance perspective, a leadership perspective, and who people see in their clinics and hospitals. I don't know about your experience, but oftentimes it's very nice to see someone who looks like you when you're walking into the hospital or walking into the clinic. But that has to be a focus of our healthcare systems to recruit and retain good minority leaders. And then finally, and I know I'm talking a lot,
No,
we've been
this is great stuff. Keep going.
Focusing on our community partnerships. It's easy for our communities to feel like we come in and we leave, we come in and we leave. But how do you come in and establish sustainable, true partnerships where you're listening, not just you're coming in and delivering to the community what you think they need, but you're actually asking them, how can we partner together with what you do need, and how do we walk this path together?
I love that. You hit on so many factors that are like key drivers to really engineering equity. The last part of what you said, I don't want to lose because there's so much power in that. And that is really leveraging lived experience to inform and shape the work. So kudos to you all for including individuals that are most proximate to these issues that are in the community to color the work. So thank you for that. You also talked about representation, and representation and diversity in healthcare is huge. There's data out there that suggests when care is delivered whether it's a nurse or physician or whomever, by someone who shares cultural proximity with you, outcomes are improved. And so I am of the mind that healthcare can't really be quality care unless it's culturally responsive. And that's when outcomes are maximized. So thank you for focusing on that, and we'll be following St. Luke's and its pledge and all the good stuff that's coming from that. I do want to come back to data in a little bit. So let's talk about training in medical schools and how medical schools can help prepare students within their training programs to be ready to focus on equity-centered care, to be equity champions, to understand what anti-racism looks like. Um, how can this be achieved from your vantage point?
That's a good question. And let me start with a couple of things. And I'm certain that you've been watching some of the dialogue around Black doctors and white coats recently.
Mm-hmm.
But first of all, I feel strongly that we need to recruit and retain minorities into healthcare. I'm a proud recipient of a scholarship that allowed me the opportunity to go to medical school. And that academic scholarship, without that, I probably would not have been able to afford to go to medical school because I did not want to leave medical school with hundreds of thousands of dollars of debt.
Yeah.
But it wasn't just the financial support, it was the support of my family. It was the support of an amazing faculty at the University of Pittsburgh Medical Center that focused on diversity and ensuring that they were diversifying their future healthcare leaders. So my first point is that we need to find ways to recruit and retain minorities in healthcare, because it's not just getting in, it's staying in. And it's staying in for the long term. And that includes having mentors to mentor you along the way, because it's not an easy path for anyone, but it can be a more difficult path if you are a minority medical student. There's also the social infrastructure that sometimes is a challenge. Many medical students have family commitments that sometimes force them to step away from their medical training. And so that structural and social support that's needed to stay in is also very important. The training that goes on within medical education, I think, is changing. I know that when I trained, I was part of an early cohort that focused on small group education and problem solving. And that problem solving included understanding the members of our community and what they may have been through. In Pittsburgh, they were leaders at the time, and it may have also reflected that, we had the Hill District that was proximate to our medical school. We had very strong minority leaders that were part of the program, but our medical students need to be able to have some type of cultural sensitivity, and whether this means rotating within communities where they're exposed to, whether it's rural, whether it's metro, but you need to understand the communities from which the people that you're seeing originate. And having experienced rotations in those communities can be revealing.
Mm-hmm.
I also had the benefit when I was training, and I'm seeing that we're getting back to a little bit more of it, of making house calls. So one of the primary care physicians that I trained with actually went into the home. And oftentimes you are able to learn more about your community by driving down their street, walking down the street, walking into their home, than you'll ever see when they walk into your office. Because when they leave your office, they're going back to that environment. And that environment has more of a contribution to their health and their care than what you see when they're sitting in the chair in front of you. So providing that breadth of exposure needs to be a core part of how we're also training our medical professionals, not just our physicians. It's our nurses, our PAs, our NPs. And then finally, I'll land by, we need to be having those conversations with our health professionals that are in training related to structural racism, implicit bias education, cultural sensitivity training, it needs to start early because if it's not part of how you're raised, it becomes difficult to train those behaviors later in your medical career.
Yeah, that's so powerful. So it's about training. I'm hearing you say it's also about really understanding what those barriers and social needs are for students entering the field. And I love the fact that you've offered real world exposure to the communities that folks will treat and serve beyond the physician. In the criminal justice system or in law enforcement, we're hearing a lot of talk about movements where police are encouraged to live among the communities that they serve
Mm-hmm.
because proximity breeds care. And so it is also in the medical system. When you are close and you have a level of understanding about the norms and the challenges and strengths of a community, you bring that and you possess that knowledge in all that you do. And so I would think that would come out in care delivery as well. So great feedback. Earlier, you mentioned data and the importance of collecting data as part of health equity. And we know we can't change what we're not measuring.
Correct.
I view data as not just quantitative, but also lived experience, storytelling, core measures, all those things wrapped up into one. So, how can health systems begin to use data to address anti-racism and health equity from a performance improvement perspective? Give us some examples on what you're doing.
Oh, I don't know if I have the answers, but
Okay,
I can provide you with some speculations.
that would be great. That's just fine.
So probably a couple things. One, I want to go back to trust and transparency because you can't collect good data if people don't entrust you with providing those data. And I know that we have a long way to go when it comes to ensuring that our community trusts not only us as health professionals, but what are we doing with the data? And our community is so diverse, and whether it's our minority community, whether it's our community members who are undocumented, members of our community, there is some fear with how those data will be used to help them or not to help them.
Mm-hmm.
So I think there's a trust and transparency part of the conversation. I think part of it, second point, when you talk about stories or lived experiences, we're also trying to capture the individual in the data uh, in terms of what are some of those stories that help us understand what our community is experiencing. A lot of that narrative comes from the person themselves, and I'd like to collect that narrative both for the benefit of giving that feedback to our teams to understand you are making a difference, but also that narrative provides an opportunity to inform us about some of the things you're talking about related to health equity and structural racism, because a lot of the fundamental partnerships or changes that we need to make to allow our community to be healthy require some of the structural changes that need to occur. And if we don't know that, uh, there's a whole community where we know that those community members don't feel safe being physically active. So what are we going to do? How are we going to partner, whether it's with law enforcement, whether it's community partners, so that both adults and children in that community can be physically active? Or looking at a community that we're working with in Wyandotte County, where we know that there is a dearth of access to healthy foods. What are we going to go do about it? So to me, it's not just collecting the data, but it's developing initiatives that go and address some of the structural changes that will be perpetuated if you can continue to collect the data and say, yep, that's a problem, but it's going to continue to be a problem unless you go do something. So we need to have intentional opportunities not only to collect the data and review the data, but then put in place programs or partnerships that will help make those infrastructure changes so that we don't have the same generational issues occurring time over time.
Yeah.
We're at the infancy. We are blessed to be working with the Boys and Girls Club. This has been a long partnership, and we're trying to extend that partnership into more communities so that we can work with them and address cross-generational issues, not just the kids, but some of it needs to also impact their families if we want to make changes that aren't going to just be the point in time. We're also looking at, we just are in the process of completing a round of our community health needs assessment, and we invited community members to the table to have those conversations. And now we need to have some strategic plans for what are we going to go back and do in those communities to make an impact.
Mm-hmm. Mm-hmm. I love that you started with trust in this conversation and narrative. Oftentimes, narrative shapes how we act and think and what we do with and for the people that we are entrusted to take care of. So really, really glad that you called that out. You also talked about use of data, not just for the sake of collecting it, but to do something with it. And oftentimes, I see health equity treated differently in health systems than other quality improvement processes. And it's really the same process: plan, do, check, act, right? PDCA or whatever the new model is now.
Yep.
You have to do something with it. And you talked about the importance of community partnerships. I think that's critical because none of us as individual systems can address bias and racism in isolation. We have to do it in partnership with the community. So really thankful to hear that you're partnering with Boys and Girls Club. I'm sure that's a very valuable partnership to this end. Thank you. That was rich and very, very helpful. How might philanthropy partner with you, with health systems, to really address health equity as a community?
So I want to start just by commenting on one last topic related to data in PDCA.
Yeah.
We can't get into analysis paralysis because we do tend to treat equity differently. And I think people do get paralyzed. Part of it is in fear of saying the wrong thing, doing the wrong thing, meaning the wrong thing, being misinterpreted. So we need to get over that. But what I don't want to get into this point where we get all these data, but we can't do anything with it.
Right.
And I think that's where it's important for organizations like Health Forward Foundation. One, convening community conversations like you've been doing is so important. And partly because when I step back and I look at, I've been in Kansas City 9 years, and it is probably, I've lived in many communities around the United States. And I love the Kansas City community, but we can do things in silos.
Yes.
So when you bring our FQHCs to the table, and you bring our health plans to the table, and you bring our health systems to the table, we need to align and have collaborative conversations that are often facilitated by neutral organizations like nonprofits like Health Forward, because sometimes I don't want to say our competitiveness, our own barriers don't allow us to necessarily convene and collaborate in a way that results in meaningful change.
Mm-hmm.
I think having a focus on equity, advocacy, for those organizations that are seeking support from the Health Board is important. And not only that, but asking us to demonstrate that sometimes it's easy to write what you want to do on paper and request for funds, but we need to demonstrate that we're doing something, and that we're being inclusive in the work that we're doing, and that we're looking beyond the guardrails of our own comfort zone And sometimes having those difficult conversations related to racism, bias, equity, that tend to make many of us feel uncomfortable. Um, I also think it's important that you continue to help us press our leaders in terms of what are we doing to expand access to health insurance. I mean, coming out of 2020, if we don't learn anything, we need to learn that we need a healthy community. We need to make sure that people have access to healthcare, that that they're not afraid to seek healthcare, but they can also afford to go seek care when they're ill. And then if we don't find a way to continue to have these conversations, and I don't want to call it Medicaid expansion, but Medicaid improvement, um, on both sides of the state,
That's right.
our government leaders need to understand that health is wealth. And if we don't have a healthy community, I don't want to say nothing matters, but that is fundamental to being fiscally successful, successful by any other means. You need to have health in your community. So that was a
Yeah.
long rambling conversation. Being
No.
being conveners,
Yeah.
supporting applications and grants that are inclusive of multiple different groups, but also demonstrate outcomes related to those groups, and then continuing to push us to be advocates at the state and national level so that we can better serve our community.
Hmm. Those are great nuggets, some of which we are working on. Others is a challenge accepted. Let me say that. And I think it will take all of us. Health Forward is certainly rowing in this direction of really focusing on convening and establishing a common agenda.
Yes.
Because oftentimes we do find that, systems and are competing against each other, but health equity is nothing we should compete on. It's all about collaboration, and establishing an agenda for our community that we can all share. So challenge accepted in that regard, and more to come, with respect to how Health Forward and other funders can help lead this charge in partnership with our systems. Thank you so much for sitting down with me today. I appreciate it.
Qiana, thank you. I appreciate the invitation. Uh, Maybe just one closing remark that
Please.
health and care are something that, I mean, it's part of what I live for. But I don't want anyone who's listening to think that because you don't work in healthcare, that you're not a healthcare provider. So whether you are helping educate our community members, improve their health literacy, whether you're helping provide them access by helping them get to their appointments, get their medications, whether you're working with Canby or other organizations like Harvesters that are helping ensure access to healthy foods, you are a healthcare provider. Um, and I welcome all of us to the table because we all need to participate in this conversation. And more importantly, I very much want to thank you for taking a leadership role and challenging us to do better and do more for our community, because only together are we going to achieve these goals.
Very well said. Couldn't have ended it better. There's a health implication in every decision, right?
There.
Thank you. Thank you so much, Dr. Bascom, for what you're leading, and so happy you are there.